So if you're here, it's because you're trying to understand more about these changes started in 2023, how to better document your level 3, level 2 notes, to understand if how often a patient is really in a level 2 or a level 3, and try to get more RVUs, try to get the severity of illness right, try to get the medical data right. So let's start. Let me share my understanding of these codes and how can we create our notes in a way that protect our notes from down coding and from up coding. Both of them are as bad, but if we do our best and we do it from a position of trying to help a patient, the levels of severity are going to be well explained. So let's start by telling you about the changes started in 2023. The changes were a response from the governmental entities to doctors saying that they spend too much time documenting, meeting the requirements that the previous guidelines had, which you remember for the HPI, you had to collect 4 points for elements like describing a disease, and you will have to uh, try to avoid too much lingo, but try to meet the elements. And the physical exam had certain requirements of about 10 organ systems that you had to go through, and the assessment and plan had some requirements as well. Well, all of that has been changed in response to those requests. So in response to those requests, the government said, well, let's change everything. Let's let the physicians um, put more time and effort on explaining why are they doing what they are doing. So that's the point, that your goal, your efforts should be pointing towards you explaining what you're doing for your patient in a way that conveys that you are very concerned and that it makes sense to treat a patient inside a hospital, not outside, not in their homes, not in an urgent care. That everything that is for the benefit happens in the hospital. So they said, now you are going to focus only on your medical decision making, which is the assessment and plan part, and you're going to be able to just say a couple of things in the on the history and physical. On the HPI, you could say something that is pertinent to the admission of this patient, and on the physical exam, you could also say something that is pertinent. You cannot avoid not doing a physical exam or an HPI. You cannot avoid that part. You still have to do it, but you only have to do something that is what you think is pertinent. So there's not much guidance on what is considered pertinent. So it let us think that as long as the HPI and the physical exam are tightly related to the medical decision making, or what made you admit a patient or made you keep the patient hospitalized, then it is required and is pertinent. So that's a big change. You no longer have to worry about meeting criteria for HPI and for physical exam. You have to dedicate everything to the medical decision making part. Now, these guidelines also made some changes on the time required for those that like to document based on time. And they said that for the level 2 on admission notes, you have to do 55 minutes of face-to-face time. Or on the level 99223, which is the level 3, you have to do 75 minutes. And I'm sorry, it's not face-to-face time, but it's on efforts related to take care of the patient. So that's a big change on the amount of time. And the same for the progress notes, same idea. All of that, the requirements are on the medical decision making, not on the physical or the HPI or subjective part. But the subjective part and the physical exam are required for progress notes as well. Now, all the effort should be going to the medical decision making or assessment and plan. The times for the level 2 notes or 99232 are 35 minutes, and the times for the level 3 or 99233 notes are 50 minutes. So usually for me, the way I document, I always try to make it evident that the patient needs to stay hospitalized. I usually don't do soft admissions. I usually try to really explain that my patient is very sick by trying to change diagnosis to a way that is ICD-10 related. For example, I don't say confusion, I say metabolic encephalopathy. I don't say leukocytosis, I say sepsis if it's pertinent or meets the criteria. So usually my admissions are level 3, 99223. My progress notes are 99233 most of the days until I reach goal or stability of a patient, where it can be 99232, or discharge time, which usually, because of the amount of time I spend with my patient discharging, is usually 99239. So I don't build based on time. Why? Because to build based on time, you have to really demonstrate or explain what you did. No longer it's advisable to say 50% of time was spent on a face-to-face in counseling or coordinating care. No longer is advisable to say more than 55 minutes was spent with patient. Now you have to be very accurate on the amount of minutes that meet the criteria. So for a patient that is a level 3, you will have to say, I spent 75 minutes at bedside, or at bedside talking to the patient and his family, also obtaining a review of systems, also performing a medical appropriate examination or evaluation, counseling and educating patient, discussing with nursing staff, discussing with other physicians. You have to itemize what you're doing for a patient. You want to document based on time. So I think that would be more work than just doing a good note. And time also only matters for you to reach your level 3. But what if an insurance payer is trying to demonstrate medical necessity and you only mention time? Then it may be very difficult to demonstrate medical necessity. Also, if your case goes to a lawsuit, how are you going to demonstrate what you did or you didn't if your note only mentions or focuses on time? So that's why time for documentation purposes is not advisable. Um, so medical decision making, all our efforts are going to medical decision making. There are three levels: low, moderate, and high. High is the 99223 for admission, and moderate is the 99222 for admission. 99233 for progress note, 99232 for progress note is moderate. Um, so when we look at the way the medical decision making is attained or achieved, it's based on three domains. So please just bear with me for this part, that boring part, so you can understand how are we gonna get this. And once we understand things, everything is easy to get. Okay. Um, so for you to document high, moderate, or low, there has to be a combination of information that is described in your assessment and plan. This is called the problem, the data, and the risk of the patient. So if you combine these three and you get it high in 2 out of 3, then you're getting a high complexity level or level 3. If you combine two two moderates but one high, then you only get to moderate because it's the median, not one or not the highest. If you get two lows and one moderate, you only get low. If you get two highs and one low, then you get a high. So see, it's very important that at least of these three domains, you get two of them right to get your proper level, the level that you're intending. So for problem, what is the problem? The problem that you are documenting, that is the admission cost for a patient to get hospitalized or to be seen. And there's no guidance, not much guidance on what type of diagnosis made for a high, for moderate, or for low. But it says that if this exacerbation or this problem is considered to be acute and severe, then it's high. If this problem poses a threat to life or a bodily function, it's high complexity. So the way to do that is describing this as a possible threat to life or a threat to a bodily function. Let's talk about cellulitis. Cellulitis involves hand cellulitis, involving the hand, right? Hands are very, very important for everything. So it's a vital part of your body. So if you only say acute hand cellulitis, this may as well just qualify for low complexity. You change the verbiage to severe acute right hand cellulitis, then it changed the problem towards a high complexity. And on top of that, if you add to your note that the hand cellulitis comes with a high risk for abscess formation, for need for surgery to protect the function of the hand, a vital part of the human body. If you add that to your plan, to your assessment, then you're making the case for a severe high complexity problem that is affecting bodily function. So if you want more information about what determines a low problem, moderate problem, or high problem, you can look at this table and memorize it, print it. But ideally, when you describe a problem like CHF exacerbation, you describe it as acute, you describe it as severe to achieve the level 3 that you're looking at. Um, Also, identifying other concomitant problems like respiratory failure, sepsis that can be happening with your admitting diagnosis, another way to add to that severity that make for a complexity problem that as a high problem is a threat to life or a bodily function. So you make sure you have to say something like, I like to monitor his vital signs and renal function closely while he is on diuretic therapy, and that you would like to monitor his respiratory status as deterioration is very likely on this patient. Something in the lines that are appropriate to your diagnosis. Um, so that's the first part, the problem. The second part is the data analysis. What data are you really identifying on your node and how you are identifying it? In the past, we never pay attention to data. We always say, well, we'll order CBC BNP, or yes, CBC BNP, or not mentioning what the leukocytosis really meant, or how the leukocytosis tied up with the hand cellulitis or the fever. By not doing that, we were missing the opportunity to really protect our nodes from downcoding. So now data analysis becomes very important for you to say in the little three domains that data analysis has. One domain indicates or talks about the blood testing, the use of an independent historian, or the reviewing of other nodes that this patient has. Let's say a patient comes to the emergency department, is seen by the emergency department doctor, is seen by a consultant before you, and by the time you come to admit a patient, um, you have to read the notes to know what are they thinking. So what this saying is that in your note you should say something like, I review the notes by the emergency department physician and the cardiologist on call, recommending this patient to start on heparin. I agree and would like to continue heparin drip. Um, but just by saying that you review the notes, you are getting that point for you. The review of results of each unique test, let's say a CBC or a BMP were done for this patient. You can say, I review the CBC and BMP, but it's not like in the past we just mention CBC, BMP for tomorrow. No, you're saying, I order a CBC or a BMP. I review the CBC or BMP. So with just this verbiage, you can get a point to you. And then the use of an independent historian, making it a habit to mention in your note who did you talk to when a patient was not able to do that, to give you information because of confusion, because of the seizure that he just had, because of the intubation process he's undergoing. So you talk to someone else. By talking about this, by making a habit to mention this, you're getting an extra point without any effort. Like I discussed the case with the patient's daughter because the patient's unable to provide history at this time, and she said that the patient had a fall yesterday, and blah blah blah. The second domain is interpretation of tests. So for this data analysis that you need, any test that you have in the chart, like chest X-rays, EKG, you're able to say that you independently interpret it or you independently review this test, and give your analysis of it. Um, let's talk about, for example, a chest X-ray that shows infiltrates bilateral. Usually the radiologist will say, I there are infiltrates in both lungs. I cannot exclude pneumonia versus a CHF. Um, so that's the interpretation. But yours is important and even more important because you're going to see the patient at bedside. So your analysis of the X-ray, the interpretation that the radiologist provided, plus your eyes on the patient will give a result, right? So by you saying, for example, I read the chest X-ray, and then this in when you consider the presentation of this patient with shortness of breath and lower extremity edema, favors the diagnosis of CHF. By putting this interpretation together with your own analysis, you're getting this point, and you should get a habit of doing it this way because it's good practice. It's good practice towards defending your case in a lawsuit, defending your medical decisions. Now that notes are available to family members to defend and to communicate with them is another good way, very good way to practice this habit of good communication. Um, then the number three is meaningful discussion of management of tests with another physician. This is important because many doctors, when they write their notes, they like to say, I appreciate the infectious disease doctor, I appreciate the cardiologist, I appreciate everyone in the team, but no one says why they appreciate them. You can say, I appreciate them. I appreciate the infectious disease doctor for his recommendations on the management of this patient. I agree to continue sourcing IV for the next 3 days. And to treat the abscess with an incision and drainage therapy or surgery. So the purpose of this meaningful discussion means that the conversation or discussion that you had with a consultant yielded a result, yielded an evaluation that you're communicating in the note and that you agree with because you're the primary care doctor of this patient in the hospital. So see, getting this data right, the verbiage is just the verbiage. So medical decision making complexity, it can for this data you can get low complexity if you just do a little bit of results, but we want high complexity, right? So what we want is um, all the ones that we mentioned, the reviewing of previous notes, reviewing of results, ordering a test, an independent historian, discussion with another physician. So the way it will look in your assessment plan, it will be like this. The first line, admit to inpatient telemetry, as his condition carries a high risk for respiratory deterioration. And I have reviewed the year notes. I have the available results are consistent with CHF exacerbation, and I will order an echocardiogram, owning the test on your own. And I agree with the cardiologist to continue Lasix for minus IVTID by describing this, even if it takes a little longer, you're protecting your note from down coding. And then the risk part, the last part, so we can go for examples, is the risk. What is the risk? It's very simple. You just have to mention, to express in your note, to make people know through your note what can happen to a patient that's getting the therapy that you're about to provide. What about the sosine, the vancomycin, the morphine? What are the risks with the medication that you're going to give? So explaining this in your note gets for that risk. For example, you're going to use vancomycin. By saying continue the patient on IV vancomycin and monitoring renal function every day because there is a high risk for renal deterioration or renal damage, renal injury with this medication, or there's a high risk for acute kidney injury from the contrast used with an angiogram, or the patient is getting IV morphine and needs to be continuously monitored in the telemetry unit for possible cardiorespiratory arrest. It is true. Now, it may be a little exaggerated, but it is true. And that's the purpose of a telemetry unit. And you are thinking about it, you just don't feel comfortable saying that in your note because it seems a little bit exaggerated. But in deep inside you, you know that's a possibility. You want to protect a patient by keeping him hospitalized, admitting him to the hospital. So medical decision making risk, medical decision making, high risk can come from the need for emergency major surgery. And this is not just from a big surgery, it's for what you as the treating physician consider to be a high risk surgery. So it could be you saying that this patient of 90 years old with poor cardiac condition carries a high risk to develop complications with the colonoscopy that he's undergoing tomorrow. So we continue him in patient level, we continue monitoring hemoglobin levels. Then discussing codes, like saying in your note that you had a discussion with family members, a family meeting, and you all agreed that the patient will be better on a DNR code rather than full code, or transition to hospice care. That type of conversation, that type of risk that happened with this discussion can validate your note for a high risk medical decision making. And so for this part, at the end, you could add something like the patient condition is severe and requires intensive monitoring from the use of vancomycin, morphine. You could also add your code status discussion and achieve the level 3 that you are looking for. So for high complexity documentation, all right, so when you write a note, just make sure you don't write things like this one, this in this slide, because this can cause the feel that your note is actually not um, discussing a severe patient. So saying no acute distress on your physical exam downgrades the severity of your patient big time. Saying that you're admitting this patient for placement issues, that's a big no. That the patient is stable, but you want to admit to rule out ACS, that's also a no. Then why you keep a patient as stable? Calling this a social admission, or admitting because the patient is being no one is able to take care of your patient. Saying or describing a physical exam as a well-nourished, well-developed will diminish the impact of your patient. So you don't want to say those things. You may express that your patient is frail appearing, your patient is of a state age, but don't, we're trying to make a case that why a patient is severely sick and getting into the hospital. A patient that has an aortic dissection, he might be well developed, well nourished, but he has an aortic dissection. At this point, he is in pain. So why don't you focus on the pain, on the discomfort, saying distress due to chest pain instead of saying well nourished and well developed. So for those of you that use Epic or Cerner, it is possible to create a footnote with your Cerner team or Epic team, and it will look something like this, where you can first make a list of the points that you need, like the problem points, the data points, and the risk points. Of a problem point, you can say that choose one illness or injury that poses a threat to life. For the data point, you can list them here and choose the ones that you need for your level 3, level 2. And for your risk, you can list the possibilities of risk that your patient can have. And at the end, you have selected them, all of them, and it will look like this in your note. Now, the footnote is just to emphasize that you did all the steps, you mark all the boxes to get your level 3. You still have to describe what you did on your assessment and plan. This is just to help the coders know that you um, you cover all your angles, but to communicate, to provide reasoning in a lawsuit, you still need to provide the information on the assessment and plan. So the footnote idea is just to help the coders not to downcode your node and to remind you what is needed for a node.